Hi everyone, this is Dr. Vyshnavi, your ENT faculty at PrepLadder. I hope I'm audible and visible to all of you. If everything is going well, let me know in the chat box. First of all, congratulations for having completed your examination, and I'm sure that you've done it really well. ENT seemed to be all right, not very easy, not very difficult questions, but I think if you've done your concepts well during the classes, you should have been able to answer all the questions. Yes, so we are going to discuss the questions very briefly here, and eventually the complete analysis will be given on the app, and you can go and check out the complete framework of the questions and the solutions to it on the app itself. So here I would like to have your inputs to understand what was the framework of the questions and what were the exact options. This is what we have received as preliminary information from the students, but these are not the final or the exact questions which were asked in your exams. Based upon the primary input, I've made this PPT. But yes, if you have any changes or if the questions were a little different, please let me know and we will make the appropriate changes and we will go ahead to put the final version on the app. So let's begin the session with the first question, which is saying that a patient presents to you with lung injury and a tympanic membrane rupture following a blast exposure. These injuries are characteristic of which level of blast wave effect. So obviously this is not a typical ENT question. This is an integrated question and they're asking you regarding blast injuries and regarding the blast wave effects. We've known that for any hollow organ injuries, which is the lungs or the middle ear where the tympanic membrane ruptures, it's going to be level 1. Level 2 is going to be your penetrating trauma. Level 3 is going to be your blunt trauma. And that's why here, because it's hollow organs which is being affected, we are going to take up level 1 as our answer. Right. So if there's any change in the framework of the question, do let me know in the chat box and then we'll make the appropriate changes. So I think this was not a typical ENT question, so we're not going to discuss detail about it. But yeah, let's go to the second question. A patient presents to you with a fish bone that was stuck in the pyriform sinus, and during the procedure, there is an accidental nerve. Which nerve is most likely to be damaged? See, now this question has come to you multiple times, even previous years, but in a different format, in a different language. But the essential principle remains the same, which is what nerve travels through the pyriform fossa. So now if a fish bone gets stuck or whatever gets stuck, we know the nerve that travels in the pyriform fossa is nothing but the internal laryngeal nerve, which is a branch of your superior laryngeal nerve. So the correct answer will be internal branch of superior laryngeal nerve, which is sensory to the hypopharynx and to your supraglottis. So whenever anything, we also call pyriform fossa as smuggler's pouch because smugglers also hide things in the pyriform fossa, and that's why it's called like that. And we've learned this MCQ that way, that smuggler's pouch is related to which nerve, and we know that it is the internal laryngeal nerve. Correct. So I think this question, there is no doubt everyone is this question. We are not having any further discussion. Let's go to the next one, which is again a direct repeat, which is the narrowest part of the adult laryngeal airway. So we've learned in pediatric larynx, the narrowest part is going to be your subglottis. And for adult larynx, we've learned this multiple times that it is going to be your glottis. So the correct answer would be your glottis. Many times they're even confused by giving you rima glottidis as the option, which means glottis itself. So here also there is no doubt the correct answer is going to be glottis. So there's no scope of discussion. Now this is where a lot of students had confusion, lot of discussion and debate happened on the question that what surgery is being performed on the image shown, because you've never seen such an image of half of the face being opened and then you're supposed to identify what surgery was being done. Now this is a little bit of applying your common sense or understanding what's happening in the surgery. So if you see the image, this is the area of your maxilla, right? So they have removed your maxilla, they have removed the orbit, they have removed the lateral wall of the nose, they have removed the ethmoid layer cells, and they have removed the palate. And now, did we study that in total maxillectomy, in CA maxilla? Did we read that in total maxillectomy, we remove the entire maxilla with the surrounding structures, which is the palate, ipsilateral eyeball, ethmoid layer cells, and the lateral wall of nose? Yes. So if you just recollect that line and apply it on this image, it would be very, very easy. And we've also discussed the Weber-Ferguson incision that we use for total maxillectomy. So this incision itself should prompt you to the correct answer, which is total maxillectomy. So the correct answer is maxillectomy. So whenever we're talking about ethmoidectomy, right? So whenever we're talking of ethmoidectomy, we are going to do Lynch-Howard incision, not the Weber-Ferguson. Lynch-Howard starts from your eyebrows and goes down along the nasolabial sulcus, midway between the nasal bridge and the medial canthus. So here, that is the incision that you would see for ethmoidectomy, and here the incision is Weber-Ferguson, that's for maxillectomy, right? Okay. So yes, there's a question on inspiratory stridor. Yeah, we'll be coming to all those questions eventually. Okay, medial maxillectomy was not there in the option. Okay, was in the option. So ideally, this should be for total maxillectomy. For medial maxillectomy, we don't do external approaches any longer. We do endoscopic medial maxillectomy. So they wouldn't show you an external approach or an external incision when they're talking to you about medial maxillectomy. So that is relatively a less probability to be the right answer. So I think that total maxillectomy only should be the answer. If there's any discussion, do let me know in the chat box. Okay. The next question, human papilloma virus infection is most strongly associated with which of the following head and neck cancers? So HPV we've learned is responsible for causing, laryngeal papillomas, juvenile onset recurrent respiratory papillomatosis. That's the first thought that strikes your brain when you see this question on HPV. But is that the question? No, they're asking you a question on cancers. So when we talk of HPV related cancers, the first thing that should strike to your brain should be oropharyngeal cancers. Yes, the tonsillar cancers. So oropharyngeal cancers are associated with HPV. For nasopharyngeal, you should remember it is most commonly associated with EBV. Hypopharyngeal and laryngeal are mostly because of carcinogens like smoking, alcohol, and they have very less predilection for a virus to cause the cancer. So if they're asking you HPV and strongly associated, the first answer that you should think of should be oropharyngeal. Yes, so everyone here is agreeing to it. So we'll not have any more discussion. Let's go to the next question. A professional singer presents to you with difficulty in raising the pitch of her voice after thyroid surgery. There is no hoarseness, but the high pitched voice production is impaired. Which nerve is most likely injured? So we've again learned this question in the nerve palsies that whenever we talk of breathing, or if a patient is having stridor after thyroid surgery, the most common nerve to be injured will be your recurrent laryngeal nerve. But whenever the voice is affected, tone is affected, pitch is affected after thyroid surgery, which nerve injury should we think of? Yes, it's going to be your external branch of superior laryngeal nerve. This external branch of superior laryngeal nerve supplies which muscle? It supplies your cricothyroid muscle. And what is cricothyroid? It's the only or primary tensor of your vocal cord. So if it cannot tense and if the vocal cord cannot stretch following nerve injury, what will happen? The patient or the singer cannot raise the pitch of their voice, right? So the correct answer should be the external branch of superior laryngeal nerve. So I hope all of you have got this. Okay, so now let's go to the next question. The image is showing to you that the highlighted area in the front of ear is having an abscess. So which type of abscess is most likely to occur in this area? So if you see here, this is the area where they have pointed to you that there's an abscess. Now, following mastoiditis, we've learned that there are multiple abscesses. We've learned that if the pus trickles into the sternocleidomastoid muscle, we call it as Bezold's abscess. If it goes into the digastric, then we call it as Sitelli's abscess. Most commonly, it breaks the outer cortex and lies behind the pinna, which we call it as the post-auricular abscess. And now, if it goes anteriorly to the zygoma, we call it as zygomatic abscess. Yes, so all of you are agreeing to this question also. Zygomatic was there, ma'am. So fine. Our answer is going to be zygomatic abscess. Yes. So the correct answer is zygomatic. Yes, zygomatic abscess, the abscess will be above the pinna on the zygoma, right? So it could be above the pinna. The pointed area could be here. So this is the right answer. Okay. Yes. A patient presents to you with enophthalmos and periorbital ecchymosis after being hit by a ball. What is the most likely diagnosis? So this is again a common repeat that you see whenever there is a ball injury to the eye. We know the most common wall of the orbit that is prone to injury, that is liable to break because there is no resistance, is going to be the floor of the orbit, and that results in a teardrop fracture or teardrop sign that we see on the x-ray. This is called as the orbital blowout fracture. Yes. So this thing, I'm sure everyone has got it. So I'm not going to discuss any further. Let's go ahead. The tip of the uncinate. Now this is a bouncer question because we've never discussed this in our sessions. This is not expected for you as a foreign medical graduate to know also that where is the uncinate process attached superiorly. This is not even a NEET PG or an INI-CET question, and this is a question typically asked for ENT residents and less commonly for MBBS graduates. But yes, I will explain this to you. So whenever we're talking of uncinate process is the gateway to the middle meatus or the entry to the middle meatus. So uncinate could have its attachment anywhere, right? So it begins its attachment inferiorly from the inferior turbinate. So this is your inferior turbinate, this is your middle turbinate. So the uncinate begins inferiorly from the inferior turbinate, and it could have one attachment to the lamina papyracea of the orbit. So this is your orbit, and this wall is called as the lamina papyracea or the medial wall of the orbit. So one attachment could be to the lamina papyracea. The second attachment of the uncinate could be to the base of skull. And the third attachment of the uncinate could be to the middle turbinate. So uncinate could attach to any of these three areas, either to the lamina papyracea or to the base of skull or to the middle turbinate. Yes. So yes, some of you, Ketan, you're telling that it's very unfair for board members to ask such questions. I agree, but then they have to give one or two bouncers, and you can expect one or two bouncers. And if you've not done, many of them will not do, so it will not affect you overall. But yes, this is definitely not a question to be asked for FMG. That I'll agree with you. Yes, so lamina papyracea was there, fine. So if it is lamina papyracea was there, then you can answer lamina papyracea. If not, middle turbinate will be the right answer. So the superior attachment of uncinate could be attached to any of these three structures. Just check what was there in your exam options and give me that answer in the chat box, and then you will know the answer for yourself. Yes, now let's do the next question. A patient presents to you with a history of fall and is having bleeding from the ear on examination. What is the investigation of choice? So we know that ear or our pinna or our external auditory canal, the bony part lies in the temporal bone. So whenever we're talking of bony anatomy, we know the investigation of choice will be CT scan. Now, if the patient is having a fall, we're thinking of fracture, right? Because there's blood in the canal. So whenever we're thinking of fracture, of course, you're not going to go for MRI, right? So MRI is gone, CBC is gone. Now what is left? CT scan, right? So CT scan of the temporal bone will be the right answer. Yes, so that is the right answer. All of you have marked it right. Very good. Now let's go to the next question. A male patient presented to you with high frequency hearing loss that worsens in noisy environments. Now typically, what is the meaning of high frequency hearing loss? So if we draw the audiogram, the hearing loss is more at higher frequencies like 150, 200, 125, 250, 500, 1K, 2K, 4K. If I take, the hearing loss is more towards higher frequencies at 1K, 2K, 4K hertz. But at lower frequencies, it's all right. This downsloping type, we've read it multiple times, this downsloping type of audiogram is seen in which condition? Presbyacusis. Yes. Now, Pulio's phenomenon, Meniere's disease, some of you are telling me, but tell me what happens in Meniere's disease. In Meniere's disease, did we read high frequency loss or did we talk of low frequency loss? And why did we talk of low frequency loss in Meniere's disease? Because in Meniere's, there is increase in the endolymphatic pressure. And now when we talk of the cochlea, which is the narrowest turn, the basal turn or apical turn? Apical turn. Now apical turn, if it is the narrowest, it is responsible for recognizing high frequency or low frequency. Low frequency. So the first to be affected in increased endolymphatic pressure will be the apical turn, and the first frequencies to be affected will be low frequency. So low frequency, if they would have given, I would agree to you for menias, but since they have not given this, you are going to choose presbyacusis. Now you'll tell me why they are having worsening in noisy environments. That's because the speech discrimination has got affected. Age-related hearing loss, you would see that the ability to discriminate the words or discriminate the speech, it gets affected, and this becomes worse when they are in a noisy environment. So this answer has to be presbyacusis. Now there was a similar question which I got, which I will discuss with you right now, is this question. A 60-year-old male present to you with gradual progressive hearing loss and difficulty in hearing conversation, especially in noisy environment. Now, I don't know if this was the language of the question asked to you in the exam or the previous one, but for both the answer will remain to be presbyacusis. Okay. So whether they had asked you in this format or the previous format, the answer has to be presbyacusis. If they would mention to you low frequency, then okay, Menius is the right answer. Okay, so now let's go to the next question. A diabetic male presented to you with facial pain and blackish discoloration. Now, this is again a giveaway question. Whenever you've heard of blackish discoloration in the nose, post-COVID, we've seen this question is occurring again and again. There is involvement of the bone and sinus. What is the most likely diagnosis? We all know this. Post COVID, we have seen blackish discoloration, S-char, necrosis. What is the answer? The answer has to be mucormycosis, right? So if you see here in the image, they have shown you areas of erosion, which indicates to you that this is an angio-invasive fungus invading the bone, invading the soft tissue. The word blackish discoloration indicates that this is invading the blood vessels to cause necrosis and ischemia to the tissue, and hence the answer has to be rhinoorbital cerebral mucormycosis. Simple bacterial fungal sinusitis will not cause, only invasive fungal will cause, not a non-invasive fungal sinusitis. So these are not the right answers. The correct answer has to be mucormycosis. Again, the next question is a very easy one. A tympanometric graph. We have discussed this multiple times. Whenever you have a short compliance, if you see here at 0, the graph is below the half of the y-axis. I keep teaching you always, if you have to see the peak. If the peak is at 0, occupying half of the length on the y-axis, we call it as A. If the peak is at 0 and occupying less than half of the length on the y-axis, we call it as AS. If there is no peak at all, we call it as AD. If you have a simple flat line, we call it as B. And if the graph is shifted to negative pressures, we call it as C. So here they have clearly shown to you an AS type of graph. So the correct answer has to be AS. Yes. Okay, United, if there was no direct option of mucormycosis, can you tell me what was there? Was it invasive fungal sinusitis? You cannot put the endotracheal tube. What would you do next? So if you can't put a endotracheal tube, do you think nasopharyngeal airway will work? Of course not. Do you think laryngeal mask airway will work when you cannot intubate a patient? Won't work. Bronchoscopy also requires you to have intubation, requires you to pass from the upper airway. So this also won't work. The only way you can secure the airway in such an emergency would be to do a cricothyrotomy, where you pierce the cricothyroid membrane and you enter the airway to secure the airway. But you cannot keep the patient on cricothyrotomy for a longer duration of time. You have to convert it to a tracheostomy eventually. So the correct answer will be cricothyrotomy. Yes. So, Ketan, I think you're telling tympanometry was asked with respect to adenoid hypertrophy. I think I have the question here. Let's discuss this here. A 5-year-old child is brought to the outpatient department by his mother with irritability, poor school performance, and a history of recurrent ear infections. Otoscopic examination is showing to you dull, retracted tympanic membrane with a fluid behind it. There is no blood clot present in the ear. What is the most likely diagnosis? So, if Ketan, you say this was the question with a B type of tympanogram, what would you think? Ranjan Sahani, this question was not there. Okay, so if it's not there, fine. But if it was there, then the answer is very clear that a child is having poor school performance, retracted tympanic membrane, fluid behind it. It's suggestive of otitis media with effusion. Okay, so this question was not there. So we'll mark it as a no question and we will not discuss this because you guys are saying this wasn't there. Okay, Chetna is saying it was there, but anyways, there or not there, we know the answer has to be otitis media with effusion because dull tympanic membrane, fluid with behind it, poor school performance, all of these words, buzzwords point you towards the diagnosis of otitis media with effusion. Yes. So I think with this, we are done with discussion of the 18 questions, which is a little high in number because usually we get 10 to 12 questions from ENT, but this time there were about 18 questions. And if there are any questions that you think were there, please do let me know in the chat box. We will add all of them and make a final presentation for all of you that will be uploaded on the app soon. The previous question, adenoid history. Okay, so maybe they have given you mouth breathing, snoring, such question in a child. Ketan, if that was there, then fine. We will have to think about again otitis media with effusion only, but maybe the framework that you're saying could have been different. Yes. So with this, I think I am done discussing the questions with all of you. Just take rest for now. Don't think too much about how many corrects and how many wrongs you've done. You've done whatever you had to in the exam hall. Now just relax, take rest, and the results will come, and whatever will happen will be for your good. So just take care, and I will see you all again. Until then, take care and bye bye.